So we identify this situation when a patient presents with acute coronary syndrome and there is difficulty in crossing or dilating the lesion, or there is evidence of heavy calcification or diffuse disease, and often they have well-formed collaterals. This is a 68-year-old gentleman who presented with acute inferior wall ST elevation MI, and he had symptoms for about 12 hours. This was the angiogram, left side moderate disease, and collaterals are seen filling the distal right coronary artery. And this was the lesion RCA mid total occlusion. We thought it was an acute, but we had a lot of difficulty in crossing the lesion, but finally managed to cross with the fielder XT, but the balloon could not be advanced. So I had to change to Amplatz system, and then we were able to cross with the balloon and complete the study, complete the case with 2 stents. Now, these patients may present as ST elevation MI or NSTEMI, or sometimes just unstable angina and maybe new onset exertional angina. And sometimes they present very dramatically with acute pulmonary edema and cardiogenic shock. So there will be some atypical features, and the ECG may not be the usual typical ST elevation MI, and there may be discordance between the ECG and the echo findings. So as I told, these are fibrotic calcified lesions and often need CTO wires, and often need adjunctive devices to complete the PCI, like cutting balloon or rotablator. And management options in the primary PCI ST elevation setting, we may complete the stenting if we are able to dilate the lesion and go ahead, often without using any adjunctive devices. Use of rotablators in this situation is a little tricky. And true acute occlusion will have variable amount of thrombus, so there's always some risk of rotablation. So the plan is, most of the time we just do the thrombus aspiration and balloon dilatation, and then stage them for stenting, or stage CABG, or sometimes even medical management. So the rotablator use, there is very few cases of anecdotes where people have successfully used rotablator in acute MI ST elevation. However, in one Japanese study of about 150 patients, there was a much higher incidence of periprocedural slow flow and periprocedural MI. So the rotablator is not the ideal thing to try in patients with acute coronary syndromes, even though lesion looks like a chronic one. So here is a second patient who presented with, again, inferior ST elevation MI, symptoms 8 hours duration. So there was moderate disease in the left system, and this was a heavily calcified mid-RCA total occlusion, and we knew from the beginning there's going to be difficult thrombus aspiration attempted, and then the balloon dilatation was done. We got TB3 flow established, but the balloon was not fully expanding. So we stopped at this stage, and later we also felt that the thrombus amount was not that much. So we brought him back 2 days later, and we did a OCT, and that showed only a small amount of thrombus but heavy calcification OCT films. Then we did the rotational atherectomy with 1.5 bar and completed the procedure with good results. Now here's the third patient who had symptoms for 2-3 days and 3 hours of worse pain with ST elevation in the anterior leads, and he had a positive stress thallium in 2015. So chronic disease, right coronary non-dominant, the left coronary LAD total occlusion and calcified lesion. So we are unable to expand the balloon here. So again, we thought we'll defer it, we'll bring him back a little later, and he was very stable. So TB3 flow, we left it, we treated him antiplatelets and low molecular heparin, and we were planning to do PCI 2 weeks later because he wanted to, not ready to stay in the hospital too long. So he had no symptoms, but when we brought him back, he had closed again. Because of the well-formed collaterals, he has had no symptoms at this time. So this time again we tried thrombus aspiration but didn't work. Then with the 2 millimeter balloon we opened, and then we did the rotational atherectomy with 1.75 millimeter bar, and then the stenting extended to the left main with good results. And sometimes this is another patient who presented with acute pulmonary edema, and he had diffuse ST segment depression, and the echo showed global LV dysfunction, and both LAD and RCA showed slow flow with calcified lesions. It wasn't even clear which was the culprit, but we thought most probably LAD because the RCA lesion looked even more chronic than the LAD. So we tried to open this, it was not opening well. Did the balloon, we got TB3 flow, but calcified vessel, we are not comfortable stenting this lesion directly. So we also opened the RCA that also behaved like a true CTO. Fielder XT, and then Confiance Pro 12 wire we had to use with amplitude support. And balloon was not expanding well. Again, we got TIMI3 flow in both vessels. We left it, and we advised him actually go to bypass surgery, but he was not keen on that. We brought him back 2 months later and did rotational atherectomy of the LAD, followed by stenting, and also RCA, 1.75 bar. So here is another patient, 75 years old, presented with 3-hour symptoms, RBBB, ST elevation in the anterior leads, RCA CTO, and LAD slow flow and being the culprit. Here also calcified disease and balloons not expanding properly. So what we did at this time, we put a balloon pump and stabilized him, and he underwent actually bypass surgery. So here is another patient who presented with 1 month history of exertional angina, and he showed LAD total occlusion, but there appears to be a microchannel and there's a lesion in the diagonal. So which we were able to cross with a Fielder XT and complete the study in the first sitting with 2 stents with excellent result. The balloon, the diagonal was just dilated with the balloon only. So in conclusions, acute occlusion of severe chronic stenotic lesions is not uncommon and usually present as ACS with the wide spectrum and identified by extensive calcification and difficulty in crossing or dilating the lesions. Management depends upon the presentation as well as the extent of CAD. In patients with STEMI or pulmonary edema, immediate restoration of TIMI3 flow should be attempted, thrombus aspiration if possible, and POBA with small balloons, and proceed with stenting if the balloons expand well. And for non-dilatable lesions needing rotablator, it's better to stage the procedure if the flow is established. And for low surgical patients with multi-vessel disease, and stage CIBG should also be considered.